Hello guys, welcome back to my channel. So in this video we will discuss rest of the things like washout CT protocol, chemical shift MR imaging and few of the adrenal pathology. So let's watch. Let's first look at the typically benign adrenal incidentalomas, which doesn't require any further imaging follow-up. So they are basically typically benign. Okay. So the first is lipid-rich adenomas, because their HU on the non-contrast CT images itself are less than 10 HU, or they show signal drop on opposed phase MR images. We'll discuss this later. So first is lipid-rich adenomas. Second is the myelolipoma. Myelo means bone marrow elements and lipoma means fat. They have gross macroscopic fat visible on NCCT images with attenuation of fat, okay, in like minus 30, minus 40, minus 50, etc. Next are the cyst. A cyst follow water density with no post contrast enhancement. Hemorrhages also, they don't show any enhancement. In cases of adrenal hemorrhages, we have to look at the clinical scenario also, like the patient is having trauma or any acute severe illness where they present with adrenal hemorrhage, and they don't show any enhancement. Next are the benign calcifications that include coarse, curvilinear or septal calcification. Next is the unchanged adrenal lesions which do not change compared to prior imaging, like on follow-up imaging of more than 6 to 12 months there is no change in the lesion, but there is a catch: there should not be history of any carcinoma and the lesions which do not show enhancement. Okay, and by that we mean the difference between the contrast and the non-contrast images is less than 10 HU. So these lesions are typically benign adrenal incidentalomas and they do not require any further follow-up imaging. So let's see the images. So it is adrenal lipid rich adenoma because the HU is less than 10 on NCCT, cyst of water density, cyst with coarse calcification, cyst with septal calcification, and the myelolipoma with gross fat, and there can be foci of calcification also. These are the typically benign lesions. Let's look at them again. The adrenal adenoma with HU of less than 10 on NCCT images and showing signal drop on out phase images. Okay, so this is the, I will discuss these later. Okay, in phase and out phase, all these things. So there is signal loss in the this gets darker in the out of phase images. Next is the myelolipoma, where we can see a lesion with well defined borders, some internal heterogeneity of following the gross fat attenuation, for example in this case minus 30 HU, and on post contrast images they show a subtle enhancement also because they are less vascularized. Okay, next, for example, here it is the adrenal cyst, T2 hyperintense adrenal cyst. So these are the typically benign lesions that do not require any imaging follow-up. Okay, so we have discussed these category. Next one, we have to look at the additional imaging. We are not discussing the PET CT here, but let's look at the washout CT protocols and the MRI with chemical shift imaging to determine these lesions. Okay. So when the adrenal lesion is not a typical benign lesion on NCCT images, we can go for the adrenal washout CT protocol, okay, the adrenal CT protocol, or we can go for chemical shift MR imaging. Okay. So what is adrenal CT protocol? We do a NCCT non-contrast image, then we do a contrast image of at approx 60 to 90 second delay after contrast injection, like for example 70 seconds, and then we do a delayed scan at approx 15 minutes of post-contrast injection, and then we calculate the Hounsfield units of the lesion in all the phases, and what we calculate is the absolute washout of contrast and relative washout. Okay, so what is absolute washout? This is calculated by this formula: HU of the lesion in portovenous phase minus HU of the lesion in delayed phase divided by HU of the lesion in portovenous phase minus the HU on the NCCT images into 100. If this comes to greater than or equal to 60%, we are dealing with lipid poor adenoma. Mind you, lipid rich adenomas are diagnosed on NCCT itself of HU equal to or less than 10. Okay, it's the lipid poor adenomas, and we have to differentiate it from other differentials of adenocortical carcinoma, pheochromocytoma, and metastasis mainly. Then we have to do this adrenal CT protocol. If the absolute washout is more than equal to 60%, it's adrenal lipid poor adenoma. And if the relative washout is like more than equal to 40%, we are again dealing with lipid poor adenomas. It is calculated portovenous HU minus delayed phase HU divided by portovenous into 100. This is usually calculated when we don't take the NCCT baseline images. Then we have to go for the relative washout. Okay, more than equal to 40% is like for lipid poor adenomas. But there are some pitfalls, like this adrenal CT protocol is mainly to differentiate lipid poor adenoma versus 3 differentials. Okay, but there is a catch that these lesions also can contain microscopic fat, and these lesions also can cause washout in these ranges: the adenocortical carcinoma, pheochromocytoma, and metastasis, adrenal metastasis, typically from HCC and RCC, the hypervascular metastasis. These also can show washout in these ranges. Okay, so this is the adrenal CT protocol, where we have to calculate the absolute or the relative washout percentages, and we can differentiate lipid poor adenoma versus these differentials, but remember the catch also. And another thing we can do is the chemical shift MR imaging. I'm not going into the physics of chemical shift MR imaging, but I will suggest you to read that also. But because if any adrenal case comes into your exam, then the examiner must will ask you the physics of chemical shift imaging. Okay. Next is the chemical shift MRI imaging. So in addition to the CT washout protocol, we can also do chemical shift MR imaging, where there are 2 approaches. One is the ASR, that is adrenal to spleen CSI ratio, chemical shift imaging ratio, and another is the adrenal signal intensity index, ASII formula. Okay, so ASR formula, this is actually calculated via this, and if the values are less than equal to minus 35.9% at 1.5 Tesla, or that is less than equal to minus 17.2% at 3 Tesla, this is diagnosis of adrenal adenoma. And for this ASII, adrenal signal intensity index formula, this is actually the formula, and the cutoffs are for the diagnosis of adenoma are equal more than 16.5% at 1.5 Tesla, and it is more than 1.7% at 3 Tesla. Okay, so this is actually the chemical shift MR imaging. When to prefer what is also a question, when you should do CT washout protocol and when you should do the chemical shift MR imaging. Okay, so MRI is preferred whenever there are contraindications to CT contrast. For example, contrast allergy, renal insufficiency, patients are very younger, no ionizing radiation should be there. Okay, and also when the non-contrast CT density is more than 10 HU but lesser than 20 to 30 Hounsfield units, these are the indications for MR imaging. And when washout CT is preferred, when the non-contrast CT density is more than 20-30 HU and no suspicion of adrenal hemorrhage is there. Okay, whenever there is suspicion of adrenal hemorrhage, MRI is preferred. Okay, so this is a chemical shift MR imaging. Now let's look at the examples here. So this is the washout CT protocol, where the unenhanced HU is 24, venous 60-second HU is 88, and the delayed 15-minute HU is 49. The absolute or the relative washout percentages are calculated, and these both fit into the category of lipid poor adenoma. Okay, also on the chemical shift imaging, the qualitative way, in phase and out phase, where the signal loses its signal on out of phase images, the qualitative way, it is lipid poor adenoma. Okay, and the quantitative is by these two formulas, the ASR and the ASII formula. Okay, these things you should keep in mind. So this is how we differentiate the lipid rich adenoma, lipid poor adenoma from all the other differentials of pheoadenometastasis. Also, mind you one thing that this out of phase chemical shift imaging is not appropriate for myelolipoma because they have gross fat, they have extracellular fat, and these extracellular fat actually do not cause signal drop on out of phase images. Okay, so for the myelolipoma, CT is very good, or T1 MR with FAT-SAT T1 is good, but not the in-phase and out-phase imaging. Okay, and also remember that lipid-poor adenomas have very minimal fat, intracellular fat, and this intracellular lipid do not cause signal drop on FAT-SAT images. Okay, so so remember this T1 versus T1 FAT-SAT and the in-phase and out-phase imaging. This is for myelolipoma because the extracellular fat there is it causes signal to do on fat sat images, but the in phase out phase for intracellular fat, and this intracellular fat is responsible for the drop off signal on out phase images. Okay, so myelolipoma is this T1 and T1 fat sat images. So in the next part of this video, we'll actually discuss few of the rest of the pathologies like pheochromocytoma and adrenal cortical carcinoma and metastasis. I think I have made things easier for you to understand. If you have any doubts, you can ask in the comment section. Thank you.